Hi, welcome to Guts and Glory, the podcast which delves deep into the complex world of gastrointestinal and HPB disorders. Join me every month, wherein we unravel the mysteries of these complex issues in candid conversations with leading experts who share their experiences, tackle contentious topics, and provide cutting edge insights. I'm Sadiq Sikora, and this is Guts and Glory. Good evening. Welcome to the podcast Guts and Glory, wherein we decode the mysteries of complex GI and HPB issues. On this podcast, I have a special guest. He is a dear friend, mentor, and colleague, and he has been with us, and I've been with him since a long, long time. Dr. V.K. Kapoor, whom most of the audience who's been listening to this podcast would know him. Dr. Kapoor was a faculty at the All India Institute of Medical Sciences, where I was his resident and then registrar. Subsequently, he moved to SGPGIMS Lucknow, one of the premier institutions of the country, wherein he established the Department of GI Surgery, which later became the Department of GI Surgery and Liver Transplantation, wherein he trained and mentored a whole generation of students in GI surgery. After retiring from SGPGIMS, he is now at Mahatma Gandhi Medical College and Hospital at Jaipur, where he heads and leads the Department of GI Surgery and Liver Transplantation. He also wears the hat of a pro-chancellor at the Mahatma Gandhi University of Medical Sciences and Technology. So he has a lot on his plate, as we can see. And therefore, I am doubly delighted to have him on this podcast. I must say that Dr. Kapoor, to begin with, when we interacted with him, we realized that he's an astute clinician, he's a patient advocate, and he is a wonderful surgeon. But on top of all that, he is a teacher of teachers. He does not lose an opportunity to teach even after so many years. And the students uh, delight themselves in picking his brain and learning every time they interact with him. He's been bestowed with the highest national award for a teacher, the B.C. Roy Award, and he has continued his teaching programs when he moved to Jaipur by establishing the Jaipur Surgical Festival, the Jaipur Surgical Tutorial, and many online programs to benefit students both in India and abroad. He's a prolific writer. I wonder where he gets the ideas and the time, but he has written more than 300 peer reviewed articles in journals and several chapters in textbooks and several books he has published himself. He is a researcher par excellence, and it is evident from the fact that he puts his mind to a problem and tries to find solution of these problems. And we'll talk about this in this podcast. If I continue, it'll take the whole podcast. So I'll stop here and welcome Dr. Kapoor. Thank you so much for being on this podcast. It's really my pleasure.
Thank you, Sadiq. I'm happy to be uh, participating in this new venture which you have just started. Sadiq and I, we have worked together at the All India Institute of Medical Sciences, and then we had an innings together at the SGPGI. And after he moved to Bangalore, we still connected with each other through our online teaching portals, as Sadiq has mentioned. So I'm very happy to be participating with you in this podcast. Thank you.
Thank you, Dr. Kapoor. And now, as I said, that Dr. Kapoor's expertise is in many areas, but he is synonymous in India and abroad with a disease called gallbladder cancer. He's a gallbladder cancer man. And certainly, that's what we are going to talk about here. It has many facets, many areas in gallbladder cancer, but we'll focus in some of the niche areas, especially the controversial areas, and see how best we can pick his mind and understand this complex disease. Uh, Dr. Kapoor, what I want to start with, we were together at SGPGI. I joined in 1990, you started in 1988, and we, of course, saw many patients with gallbladder cancer. But I realized that there was very little we could offer to these patients. They came in advanced stages, in very bad shape, and even palliation was difficult. So, what drew you to this problem? What prompted you to take this up and make it a kind of mission of your life? I would like, and many others would like to hear what was going through your mind when you chose this.
The story of my association with gallbladder cancer goes back to late 80s when I was at the All India Institute. You were also there. And Dr. Blumgart, who was the doyen of hepatobiliary surgery, he was to visit the institute and the department. And the departmental faculty was discussing as to what to present to him. And one topic which was suggested was abdominal tuberculosis, but then everybody thought that he may not be interested because they don't see it in the West, at least at that time. So I was a very young faculty member at that time and very uh, carefully and
Yes.
cautiously, I made a suggestion. Why don't we show him something which is close to his subject, but which is more common in India and not in the West? And we knew by that time that gallbladder cancer is not a disease of the West. So, myself and one of my other colleagues, Dr. Arvind Kumar, we were given the responsibility of taking out the data of the last 5 years under the guidance of Dr. Chattopadhyay, and this was presented to Dr. Blumgard. The article was later published also, and probably that was the only article which carried the names of all the heads of the 4 units of the All India Institute of Medical Sciences Department of Surgery because the data was from all 4 units. And then after a couple of years, when I moved to SCPGI, I still remember we had just started our outpatient services, and Dr. Sandeep Avasthi used to be a senior resident with me. And I realized that in every OPD, we were seeing at least one or two new cases of gallbladder cancer. And this is when SCPGI had just started. We were far from the city. It was not a free hospital, it was a paying hospital, paying government hospital. And then it struck me that probably gallbladder cancer is even more common in Lucknow than it was in Delhi. And I asked Sandeep that let us keep records of all the patients that we are seeing, and he very diligently did it. And within a year or so, we realized that it is definitely a very common disease. And then
Right.
we started keeping prospective data. And as you rightly said, that this is a disease where even now, and more so at that time, there was no treatment. In fact, the title of the article, which was published from AIMS, was Gallbladder Cancer, Can We Do Anything? And I'm sure the question still remains valid. And
Yes.
then I thought that we should try to find out why it is common, what is the relationship, is it coincidence or causal relationship with stones, and that is how the interest and then
Yeah.
residents including you contributed to all this data keeping publications, and gradually the institute became known for its clinical experience in
Yes.
gallbladder cancer, first in the country and then all over the
Yeah.
world.
Yeah. So, Dr. Kapoor, some of the things about gallbladder cancer which foxes people is that there is a spectrum of disease and there are various nomenclatures associated with that. I mean, there is something advanced, there is metastatic, there's early, incidental, true. So, just let's make the air clear by just defining the nomenclature so that we know clearly what we are talking about.
Yeah, as you rightly pointed out, that gallbladder cancer is a peculiar cancer or disease where the diagnosis is made at several stages, and the clinical picture does confound with other conditions, and most commonly gallstone disease. And the two coexist also, as we know, in about 60 to 70% of cases.
Yes.
So many years ago from the SGPGI, we did suggest that there should be a standard nomenclature. And what we suggested was that if the patient has obvious clinical features, which is history and examination, which suggest a diagnosis of gallbladder cancer, and that would be a middle age or elderly lady with continuous dull ache, with or without anorexia, weight loss, biliary obstruction, gastric outlet obstruction, and a palpable firm to hard mass in the
Right.
upper abdomen. This is what we said is clinically obvious gallbladder cancer. And unfortunately, majority or most of these cases will have advanced, even metastatic disease where nothing much can be offered to them. So next is when the clinical picture is like gallstone disease, biliary colic, you do an ultrasound, but on the ultrasound, you find something wrong, something more than a gallbladder with stones only. This, we said, should be called a suspicious or a suspected gallbladder cancer, which should be further investigated with cross-sectional imaging, CT, MRI, and maybe PET scan.
Right.
Third is when the ultrasound also shows that normal gallbladder with stones, you take up the patient for cholecystectomy, which today will be lap chole. And during the operation, you find something amiss. It doesn't look like just simple gallstone disease and chronic cholecystitis. Or you've done a simple cholecystectomy and you open the specimen, which every surgeon must. And I insist upon all surgeons that you must do it yourself, and you find there is something wrong in the specimen. So this is unsuspected gallbladder cancer.
Right.
And the last is when you've done a cholecystectomy, during the operation in the specimen, you didn't suspect anything wrong. It looks like the usual gallbladder with stones. You send the gallbladder as a routine for histopathology, and that again I insist must be done in
Right.
every case, everywhere, by everyone. And the pathologist says that no, there is something wrong, there is a cancer. This and this alone is or should be called a true incidental gallbladder cancer. And last is the category where, for whatever reason, the histopathology was not done, or even if it was done, because normally they take only three
Yes.
sections, a cancer which was there was missed, even
Yes.
by the pathologist, and the patient comes back a couple of months or a few months later with a mass, with anorexia, weight loss, biliary and gastric outlet obstruction. This we
Right.
say is missed gallbladder cancer. So that is how we suggested that the
Yeah.
nomenclature should
So
be
missed, incidental, unsuspected, suspected, and obvious. So
obvious.
that's the spectrum that you. Uh, so, roundabout way, wherever you go, the discussion eventually comes on to incidental gallbladder cancer. Uh, Naturally, because I think that's where you have an option or an opportunity to provide treatment and perhaps cure in these patients. And as you mentioned that this is incidental gallbladder cancer, but sometimes there's a talk about true incidental and incidental. Even in literature, there is a terminology about this. So can you throw some light on that and how how does it make a difference, the
Yeah.
true incidental and incidental?
Some reports do include what I suggested should be called suspected also as incidental. So if there is any abnormality in the ultrasound, or if you've done a cross-sectional imaging, the next step that during the operation you find that there is something wrong. And obviously, if you open the specimen and see something that can be grouped with
Yeah,
incidental, although I don't think that is truly incidental. And all these things have bearing on management because, as I said earlier, if any abnormality is seen in the ultrasound, if it doesn't show a normal gallbladder wall, which is less than 3 millimeter, all these patients must be investigated further with CT or MRI. Unfortunately, many surgeons still continue or stop investigating at that stage and take up the patient for lap chole. That is not correct. Any abnormality seen on ultrasound in the gallbladder wall should be further investigated with CT and MRI because that gives a better evaluation of the wall. If during cholecystectomy you suspect that it could be a malignancy, then it depends on your expertise. If I am a general surgeon who has never done or may have done one or two extended or radical choles, I would suggest that you should stop at that stage. Don't do any further dissection so that you don't violate the planes. Maybe put the omentum there, come out and refer the patient to a GI surgeon, hepatobiliary surgeon, surgical oncologist who can do a proper radical or extended chole. If you have the expertise, yes, please go ahead. And I would say that these are the cases where because clinical and ultrasound evaluation did not show a mass, which means that you didn't have a suspicion of gallbladder cancer. It is only during the operation that you are suspecting. Likelihood is that these are relatively early cases. So they
So
probably would be resectable.
we'll talk about this in a bit. But I just want to take this a little further when you said that a thick wall or some abnormality which is suggested, you have to evaluate them more. Now, wouldn't that mean that there would be an extensive amount of investigation in a lot of patients, which may not turn out to be something ominous? And would it be over investigation? Would it be, cost effective to do that in all patients? Or you still want to divide this or segregate this into a group where you should be doing it and where in others you may not do that?
So one is that as surgeons, we must request all our radiology and sonology colleagues that when they do an ultrasound for clinically diagnosed gallstone disease, they should not only report on presence or absence of stones, they should also look and report at the gallbladder wall. And as
Right.
I said, they should say whether it is normal, less than 3 millimeter, or it is thickened, which is more than 3 millimeter. Unless the patient has had a recent episode of acute cholecystitis, which can cause a thickening of the gallbladder wall for a couple of weeks, uh, thick-walled gallbladder should be further investigated because thick-walled gallbladder can be of two types. One is a diffuse, uniform, regular thickening of the entire gallbladder wall, which, as we showed from SGPGI, in almost all cases is inflammatory, chronic cholecystitis, or its variant xanthogranulomatous cholecystitis, where simple cholecystectomy is good enough. But we know that even in normal wall gallbladder, 1, 2, or 3% patients can have an incidental gallbladder cancer. This percentage increases when the wall is thickened. So it is slightly more. On the other hand, a focal, non-uniform, irregular thickening of the gallbladder wall should be considered and should be treated as cancer.
Focal.
Again, we know that focal variant of xantho is also there.
Yes.
But then uh, the approach that I recommended and I suggested in gallbladder cancer should be what I call an Indian Buddhist middle path. See, the West has a very nihilistic attitude or approach towards gallbladder cancer because in the Western literature, even for early gallbladder cancer, there is mismanagement and poor outcome. On the other hand, till a few years ago, the Japanese had a very aggressive approach,
Yes.
including what they called a right upper quadrantectomy for locally advanced gallbladder cancer. But it had very high price to pay, and the outcome in terms of actual 5-year or 10-year or 15-year survivors were very small. So what I say that one should be aggressive towards possible early gallbladder cancer, and this, the thick-walled gallbladder, the incidental gallbladder cancer, these are early forms of gallbladder cancer. One shouldn't have an aggressive approach. So, yes, I agree that some of these patients will be over-investigated, but I think it's worth a price to pay to even get a early gallbladder cancer and offer it a curative treatment.
So would you say that knowing the distribution and the varying incidents in various parts of India, that should have a bearing in how you investigate thick walled gallbladders? That could be one way because, now having worked in northern India, when I work here, I hardly get any gallbladder cancer.
I would
We
still
know that
say,
there is an Indo-Gangetic belt where the incidence is higher. It extends on into the northeast. So in these areas, maybe it is worthwhile over investigating because of the higher incidence.
but I'm sure even down south, where the incidence of gallbladder cancer is same as anywhere in the West, you would be seeing incidental gallbladder cancers, which means you do a cholecystectomy and you find an incidental malignancy. Because in all low incidence areas, including US, Western Europe, and other countries, uh, they see more incidental gallbladder cancer and less clinically obvious or suspected gallbladder cancer, whereas we see more clinically obvious
Yeah.
gallbladder cancers.
Right. So, I mean, I want to illustrate and ask you based on certain clinical scenarios so that, the audience gets the idea. So, as you said, thick walled GB. So, suppose there's a young male from UP who has a thick walled GB, no other symptoms, and symptoms of gallstone, typical gallstone disease. What would be a approach you would do or what you would suggest in that?
So I would first go to the history. If there is a recent episode of acute cholecystitis in last 2, 4, 6, 8 weeks, I would wait and repeat the ultrasound after 2 weeks, because if it is an inflammatory thickening, it would resolve or reduce. On the other hand, if there is no history of acute cholecystitis, then I will consider it as a thick walled gallbladder. And our recommendation is to investigate a thick walled gallbladder with a CT scan for a better complete evaluation of the wall of the gallbladder.
So CT does not show any, it shows diffuse thickening. So operatively, do you do anything different in thick walled gallbladder? Or if CT is all right, it's diffuse thickening, no mass, you would do a regular cholecystectomy.
Yes, so this is a dilemma. As I said, that this was the experience which was published by one of our former fellows, Dr. Shrikant, when we analyzed 60 consecutive thick-walled gallbladders, which were investigated with CT also, and they all underwent a cholecystectomy. We found that 3 out of 60 turned out to be incidental gallbladder cancers, and in these three, there was no preoperative suspicion. The CT scan never suspected, and on the other hand, when CT scan suspected a cancer, it did not turn out to be cancer. So 3 out of 60 is slightly more than what we consider as the incidence of incidental gallbladder cancer. And that is why we got worried about these thick-walled gallbladders, that they probably harbor, or like they are more likely to harbor a malignancy as compared to a normal wall gallbladder. And there is a very little and very soft evidence to say that xantho maybe I'm saying, bold capital underlined, maybe a stage between chronic cholecystitis and malignancy. Because it is an inflammatory cascade. It
Yeah.
is that xantho coexists with CAGB and CAGB
Coexist
coexists
a
with
lot of
xantho.
times.
So that is why we are more worried about these cases. So at some stage, I thought that in these 60 cases, if we have done a simple cholecystectomy where we are staying between the gallbladder wall and the cystic plate, the plane, we are probably violating the oncological plane. On the other hand, if we do an extended chole in all these cases, thinking that they could be malignant, we
So,
are doing an overkill in about 55 or whatever number of cases.
yeah.
So we thought of a procedure which is somewhere in between, and we called it an anticipatory extended cholecystectomy, AEC, where initially we said that you remove the gallbladder with the classical 2 centimeter wedge, but now I'm saying, and I have requested my younger colleagues to do even a smaller wedge, because 2 centimeter, there's no evidence. There's nothing sacrosanct about it. Even one may be good enough. So I
Yeah.
say that instead of saying between the gallbladder wall and the cystic plate, you go beyond the cystic plate in the liver parenchyma, because these are all cases where CT has shown that there is no liver infiltration. It is only a thickening of the diffuse thickening of the gallbladder wall with no any liver infiltration. So you stay in the parenchyma, maybe a centimeter wedge, maybe it will come down to even 5 millimeter. and take out this gallbladder with this small wedge of liver, subject it to frozen. That is an essential requirement. You have to do a frozen. If frozen shows malignancy in the highly suspicious area after opening the specimen, you add a lymphadenectomy. So that is why it is called anticipatory extended, that you convert it into an extended. On the other hand, if frozen is negative, then that is the end of the procedure. Now, two problems here, which anybody can say. One is that we are not taking the classical wedge. But as I said, for the classical wedge, there is no evidence. It has been convention that everybody has been saying 2 centimeter. There are no studies. So this is one area where a surgical group and a pathologist should look into all the extended coli specimens, that what is the extent of liver involvement. If it is not more than 5 millimeter, then even a 1 centimeter wedge may be adequate. The second is that if the frozen is falsely negative, then you will have to go back again as a second operation and do the proper extended coli. So this we have called AEC. And when I meet colleagues and talk to them, some groups have started practicing it. They haven't published it, but they have started practicing it.
But the third problem I can say is that a lot of people will have to do a messy operation if they are not used to doing that.
Yes.
And then that will add another dimension to the outcomes of this patient. But let's leave it there for the time being and just go to other scenario. Now, as we said, that incidental or suspected. So gross looks abnormal. You send frozen. It comes positive for malignancy. Gross looks normal. You don't send for frozen. The final pathology comes as positive. Now, what I want to understand is what is the difference in outcome of these patients when you get the result on the table vis-a-vis when you get it in the histology?
Unlike many other areas in gallbladder cancer, I don't think we have very strong evidence. We have very large evidence. There have been publications, mainly from the US, which have said that if you do a simple coli, wait for the histology, and if it comes positive, you go in again within a reasonable period of time. We'll come to that later. Uh, they said that the outcome is same as a primary extended coli for a diagnosed gallbladder cancer or a simple coli frozen section, and in the same operation, you complete extended coli. Because we have to remember that if we have done a simple coli, as I said earlier, theoretically speaking, we have violated the oncological plane, because ideally, we should have remained in the liver rather than between the wall and cystic plate. But whether it matters, because these are all early cases, whether it matters or not is something to be seen. And as we know, recently the AJCC subclassified T2, which is involvement of the muscularis propria, into A and B,
Yes.
A on the peritoneal side and B on
Yes.
the hepatic side, saying that the two are different, their spread is different, and some groups in Korea are saying that their treatment should be different, although I personally don't agree with it, because they say that in T2A you can avoid a liver wedge and you only do a simple coli with the lymph node. I don't personally agree with it. So by doing a simple coli, whether we are doing any harm to the patient in these early cases, I am not sure that we have strong evidence. But as I said, my philosophy, my teaching, and my practice has been that be aggressive in the early gallbladder cancer, because gallbladder cancer gives you only one chance.
No, what I meant was, again, just to clarify that it's the incidental gallbladder cancer, but you have removed the specimen, sent for frozen, it comes. So you have done a cholecystectomy, as was. And on the other, it comes pathology. So is the outcome really different in these two groups? Doing extended cholecystectomy at the same sitting, vis-a-vis coming back at whatever opportune time and doing it. From what,
Whatever, yeah,
yeah.
whatever soft evidence or small evidence we have, probably no.
Yeah. Now I go a step further. When we say that on frozen and it is incidental or at least unsuspected, and we plan to do an extended cholecystectomy, you know, one of the things which has cropped up of late is the lack of consent from the patient. You will take a consent from the relatives. But unless it is life saving, as has been now said in one of the judgments in Supreme Court, you cannot do a procedure just uh, on anticipation for something unless it is life saving. So I'm just concerned that you put these two scenarios together, that you take a consent, come back and do, outcome may not be different, but taking consent, and if somebody raises an objection or everything comes negative, I would say that unnecessary surgery or there is a complication. So, what do you feel about this consent thing? Because it's been talked about.
At the cost of being a possible contempt, I would like to say that I don't agree with that judgment because obviously, just as we don't understand the intricacies of law, the people who are in the business of law do not understand the intricacies of medicine. There are so many uncertainties in medicine. There are so many decisions which may have to be or need to be changed during the operation. So, and it all works on good faith. And therefore, see, for example, suppose we have gone in, say, for a cholecystectomy or an appendectomy, a relatively small operation, and we find a obvious resectable growth in the colon or anywhere else. Would we not remove it? Should we not remove it? As doctors, we all did it. But now this judgment has come in our way. So, I personally don't agree with it, but then yes, I agree that we have to follow the law of the land. But then so many times we change the decisions.
So, one other related thing I want to ask you, that if, as you said, when you suspect on radiology, you do evaluation and a kind of staging. But now, when you get the histology on the table, we have not done any staging. So, how do you sort of deal with that conundrum?
Yes. So again, you go by statistics, you go by presumptions based on your experience, based on the behavior of the disease. If there was no suspicion on ultrasound of a malignancy, because that is why we didn't do a CT or MRI. If there was a suspicion, we would have done at least a CT or an MRI. So if ultrasound showed a normal gallbladder wall, but during operation we find that it is abnormal, the chances are that it is likely to be early, non-metastatic, not locally advanced resectable gallbladder cancer. See, the
Right.
same, I'm sure we'll come to that later, that when we reoperate upon a patient with incidental gallbladder cancer, we remove a wedge of the liver, we remove the lymph nodes, and they may be negative.
Yes.
Then
Yes.
the question which the patient and the relatives will obviously ask us is, why did you reoperate when there was no disease?
So we'll come to
We'll
that.
come to that,
So
yes.
uh, fine. So we understand that there is all good faith, and these are practices which, because of lack of anything else, we've done in the best interest of the patient. Though when you look at hard data, there's nothing to separate a planned later surgery versus immediate surgery at that point of time.
Although common sense dictates that the immediate complete surgery should give better outcome as compared to surgery done in two parts separated by a period.
Okay. Uh, so let me come to this, that say patient has been diagnosed with an incidental gallbladder cancer on histology and is referred to you with this pathology diagnosis. Now, for this patient, what would you recommend people to do when they come to you?
So whatever the books may say, whatever the literature may say, for all practical purposes, almost all of these patients should be considered as candidates for a reoperation. Why I say that? The only exception is a T1A disease, which means confined to mucosa or lamina propria, which means uh, also that the cystic lymph node was in the specimen and it was negative. So it is T1A and 0. I'll come to the details a little later. There was no bile spill during cholecystectomy, and the cystic duct margin is negative. Now, in how many patients who get referred to us, the GI surgeons or HPB surgeons or oncologists from a large general surgical audience, all this information is there. How many pathologists do carefully look at all these things? Now, if the pathologist has taken one section in which T1A disease was seen, has the complete mapping of the gallbladder been done to make sure that at another place it was not T1B? Because obviously this is incidental. There was no
Yes,
lesion. It is that in one section they found.
absolutely.
So it is very, very rare that all these criteria will be fulfilled and satisfied to say that this patient doesn't need any more treatment and only close follow-up is required. So for all practical purposes, all patients with incidental gallbladder cancer are potential candidates for a consideration for reoperation because, as I said, this is the only chance to offer cure.
Yeah,
So these patients should then be investigated because initially, when the cholecystectomy was done, as you
not
rightly
yet.
pointed out, only an ultrasound was done. So
Yes,
they need to have
yes.
further investigations.
So you would do a proper staging for
Yes,
these
which would
patients,
include a cross-sectional imaging,
cross-sectional
CT and
imaging.
MR. There
Right.
is a debate and controversy about the role of PET in this
Yes,
setting because
yes.
these are relatively early. Incidental gallbladder cancers are likely to be T1, T2. Some may be
But
T3, but
you also
ideally
have
they should
T3,
not be T3 and T4.
right?
They should be
Yes,
T1 and T2. So
yes,
chances that there will be distant metastasis are low, but it is not zero. And in gallbladder cancer, if there is any distant metastasis, even intra-abdominal, like distant nodes, whatever you might do, the outcome is going to be poor.
yes.
I would say if cost, affordability, and availability is not a constraint, I personally would, I have been doing, and I would prefer and recommend a PET scan in all patients with gallbladder cancer, whether it is primary diagnosis or an incidental diagnosis.
So you stage the patient and you find with all this no evidence of disease. And then you would offer this patient what? A
Yeah.
surgery. And what would you do at surgery?
Yes. So again, like in primary gallbladder cancer, we strongly recommend and we practice staging laparoscopy in all patients with gallbladder cancer because those small, a few millimeter deposits on the peritoneum, omentum, diaphragm, surface of the liver, surface of the bowel, they cannot be picked up by any cross-sectional imaging,
Yes,
CT, MRI, or PET scan. And we know that gallbladder is a very aggressive malignancy. It spreads through the peritoneal route also, and more so in incidental where there were chances of bile spill. So
yes.
we would do a staging laparoscopy always. And if there is any suspicious deposit seen, it would be taken out and sent for frozen.
I mean, I think at this point, I just want to reiterate what you said that if you're sending a patient with gallbladder cancer, referring to a center, the referring person has the responsibility to give all this information that what were the initial ultrasound findings, the intraoperative findings, especially bile spill or not, and then ensure that the pathology is complete and all the information is there, I think, because it helps in decision making. So diagnostic laparoscopy and then procedure.
Procedure would be what is called a completion extended cholecystectomy because cholecystectomy has already been done in the index operation. So what we do now is remove the wedge of the liver, which conventionally and till today is 2 centimeter, and a lymphadenectomy. The extent of lymphadenectomy is the entire hepatoduodenal ligament, starting from porta hepatis, and then complete cauterization of the second part of duodenum and head of the pancreas, going behind the second part of duodenum and head of pancreas, and going along the common hepatic artery to the right of celiac axis.
So when would you remove the bile duct and when would you remove? Because it would depend. If the margin is positive cystic duct, that is one consideration, but you will tell us whether it always merits removal and other instances when you would remove the bile duct.
Yeah, so ideally, again, we have to request our pathology colleagues that if they find an incidental gallbladder cancer, they should probably take some more sections from the gallbladder rather than only three. They should look at the cystic duct margin in the specimen and report on it. They should carefully look whether there is a cystic lymph node around and report on it. But if that is not there, what the Tata Memorial Hospital, when Dr. Parul was there, they recommended, and they probably are doing it, and many groups are doing it, that look carefully for the cystic duct stump, which is attached to the CBD. If it is a few millimeter where safely you can excise it, it is good to excise it, of course, without
And
any risk
yes,
of injury to the bile duct, and send it for frozen. If that is positive, then probably the CBD excision should be done. Dr. Miyazaki who was formerly at Chiba University in Japan, who's done a lot of work on gallbladder cancer, his group did and showed that a routine excision of CVD as a part of primary extended cholecystectomy, and they showed deposits in the wall of the CBD,
yes,
which they said either
continue
it
to
is
deposit.
multicentric from a papillary tumor or intramural lymphatic or perineural spread. And they used to do CBD excision as a routine, but I think more and more evidence is emerging that routine CBD excision, unless there is an indication, increases the morbidity and doesn't improve the survival. It has not been our practice to do.
So I had the privilege to debate with him about CBD excision versus no, and I had the easy job of not doing a CBD excision, and it was
I
uh,
don't know whether
good.
their group is still doing it. He's moved from Chiba to Tokyo now.
Yeah.
I don't know whether they are
So
still.
another aspect, Dr. Kapoor, is the timing of reoperation. Now, does it matter or is it of significance?
So again, common sense and the conventional practice was to advise and offer the patient reoperation after, of course, all the investigations as soon as possible, because we don't want the tumor which is remaining or which has spilled because of bile spill to spread. So that was the conventional teaching, that was the conventional practice. A few years ago, this retrospective analysis of the US 10 institution consortium data came, where they divided patients into three groups: those who were operated early, which was less than 4 weeks, within 4 weeks of index coli, and an intermediate period, 4 weeks to, I think, 8 or
3 months,
some period, and then delayed
beyond
operation.
3 months.
And although this is a retrospective, uncontrolled data, somehow the result showed that in the intermediate group, the survival was better than early group. Delayed, common sense also would say. And the hypothesis or the explanation was that when you wait for about 4 weeks time, you exclude the very bad biology cases. So those who throw metastasis during this period, they are excluded, and that is the reason. Uh, there is another similar analysis from TMH, which has gone even further. They go up to 10 weeks. They say that wait up to 10 weeks because they showed best outcome in 10 weeks and all. But considering the aggressive biology of the disease, waiting without any treatment doesn't sound scientific, number one. And from patient's point of view, a patient knows that there is a cancer. You want to reoperate, but you are doing nothing. You're saying we will operate after 4 weeks or 6 weeks. He doesn't understand all these things. So another concept emerged on which trials are going on, where in this setting, after the index coli, after the histology report, you are waiting, but in this waiting period, you are giving what is called a neoadjuvant treatment for completion. It is adjuvant for first operation, but it is neoadjuvant for
Yes.
completion. Now, whether it helps, time will tell. But I
So,
personally still favor as early as possible reoperation if you are not giving neoadjuvant. In my opinion, neoadjuvant, whether in this setting or in any other setting, locally advanced, any cancer, the best advantage or best benefit of neoadjuvant treatment is this selection. If in spite of
yes.
neoadjuvant treatment, the patient progresses or doesn't show response, remains stable disease, probably whatever you might do, the outcome is going to be poor.
So you hosted the consensus meeting on gallbladder cancer in Jaipur a year and a half back. And we all had the opportunity to participate in that. And you know what struck me in the research and presentations was the fact that when you do reoperation, it is nothing more than a staging procedure. If you find disease on reoperation, the outcome is poor, the prognosis is poor. And if you don't find disease, then it's good. So the whole thing revolves around whether there is any residual disease or not. And my question, and what I've been thinking since then, is that by evaluation, if you find disease, can we only start off with chemotherapy and see what the outcome is rather than reoperate? Because actually, that's what you're doing by reoperation, finding if there is any disease to prognosticate rather than improve the outcome.
That the reoperation probably a staging procedure, because if we don't find disease, the outcome is good, which means even without reoperation, the outcome would have been good. And if we do find residual disease, the outcome is poor, which means reoperation is not helping. So, with the same idea in mind, I think again the Tata Memorial Hospital some time ago published its experience with PET scan in this setting. And they said that in T1B disease, if the PET is negative, that means there is no evidence of avidity in the gallbladder bed or in the lymph node area. They said these patients may not be reoperated. They can be kept under close surveillance. T1B, again, we didn't discuss it, but there is a difference of opinion. A lot of groups in Chile and Japan, they say that T1B simple cholecystectomy is good enough. And they have shown good
Yes,
survival. But
yes.
there are more reports which show poor survival after simple chole in T1B, and we have not been an advocate of simple chole in T1B. We have always been saying that they should be reoperated. So in this very small group T1B, the TMH, that paper at least said that if in T1B the PET is negative, then you may not reoperate. I don't know whether they are practicing it now or not, but I personally would not do it. T2, there is no debate that the patient should be reoperated because that is the group which benefits the most. T3, again, it is plus minus, but again, I feel that the patient should be given the benefit of reoperation because that is the only chance for the patient. And about the question which you said that when to give this neoadjuvant treatment, yeah, I agree with you, but there's no way to find out whether there is or there is no disease except a PET scan as of today.
Right. So I think that's what still there is uncertainty,
Yes.
wait, and therefore we need probably more focused sort of information so that we can make informed decisions for our patients, I think. But
Unfortunately, in the near future, also, at least in my lifetime, I don't see a very strong evidence will come on many of these questions. And we will have to go by conventions, by experiences, and finally using your discretion and wisdom and judgment.
I
But in
guess
all these, sorry, in all these situations, I think the counseling and consent is very, very important. The patient must know that what can happen and what may not happen.
purpose of what you're
Yes,
doing. But
yes.
do you think, just I'm extending this, but do you think, like many other areas which we are trying to do now, pan-India collection of this data of operated, not operated, or disease found on reoperation and no disease, a long-term follow-up of many institutions which have large volumes in northern India. If we put together, at least we will have some solid data to say from rather than speculate at this point based on small data which is available.
Yeah, you're right. And that is one area and many other where, in spite of spending so much time in gallbladder cancer, I admit that I have not been successful. We could have taken the lead. I think we tried also, but unfortunately could not do it. I understand the IHPBA is now collecting data from multiple institutions. I hope that that should provide the answer. But yes, there is definitely a need because gallbladder cancer is the North Indian non-gender related cancer in women. It is the commonest non-gender related organ cancer in northeastern India. And
Yes.
there is definitely a need for a good data bank of gallbladder cancer to know what the disease is and what how it behaves. We still do not know. We do not even know the answer to the simple question that how many patients whom we diagnose as gallbladder cancer, they have had a history to suggest symptomatic gallstone disease.
Right.
Such a simple thing which can be found out, but unfortunately we don't have that answer. And these are my list of what needs to be done in gallbladder cancer and what the younger generation probably should be or would be doing.
Focus on. I talk about another contentious issue. I mean, like all the ones which we have talked about now, is when you're doing reoperation, what do you do to the port sites? Do you excise all of them? Only the port site where the gallbladder has been extracted? And, something which surprised me a lot when I was part of this IHPBA program of training people as outreach programs and all, and talking to a lot of people in Bombay and many other places, it's not a customary or practice to remove gallbladder in a bag, and most people would remove that. I mean, I don't know whether it makes a difference or not, but my question is, at reoperation, all ports, selected ports, or no ports?
So it all started with some of these reports, and the largest one came from the German Cancer Registry for incidental gallbladder cancer data, where they showed that there was a very high incidence of port site metastasis. They also showed that port site metastasis were present not only in the port of extraction, but in other ports also, even in 5 millimeter ports, suggesting that peritoneal dissemination of cells is the cause.
Chimney effect of
Yes, it was
the
also
gas.
found in patients with very early gallbladder cancer, where the tube cancer had not even come up to the surface of the gallbladder. It was also found in patients in whom there was no bile spill documented, GB
Yes.
perforation and bile spill. So there was a lot of hue and cry about it, and people got worried. And that was the time when people started practicing based on this information, port site excision, and the more aggressive ones excised all four ports, as you rightly said. Some said that no, no, not 5 ports, only the 10 ports, because one of them would have been used for extraction. And some said that if you know which port was used for extraction, then only the port of extraction. But port side excision, if you have to do, if somebody wants to do, it has to be a full thickness, skin
Yes.
to peritoneum, including the parietes.
A cylinder.
Only problem is that even if you make it a cylinder with 1 centimeter diameter or radius, how do we know where did the port go? Did
Yes.
it go like this? Did it go
Or
like this?
oblique.
Or did it go zigzag?
Absolutely.
So that information, even if you have done the lab fully, you probably would not remember, you would not document.
Yes.
So one is whether port site excision helps. Second is whether this kind of a cylinder of port site is adequate enough. And if you make it wider, there is a very high risk of hernia,
Yeah.
incisional hernia, which has been documented to the tune of 10, 15, 16%. And then came the evidence again from the US and again from retrospective data. So it's not a very strong evidence, but whatever best evidence that port site excision doesn't help in terms of survival. It is the same story. If there is no tumor there, it is
Is it
not
good?
required. If it is there, it doesn't help. So again, it becomes like a staging procedure. So in SGPGI, by the time I left, I think we had almost stopped doing port site excision, although we did start with, in some
Yes.
cases,
Remember.
probably we did all four ports also at some
Yes.
stage.
Yes.
But then I think we stopped doing them, and I presume most groups are not doing it. While we are at port site excision and metastasis, there is another peculiar problem which sometimes we face. Patient is coming a few months after lab chole. Either incidental gallbladder cancer was diagnosed or not even diagnosed. It was missed. And now there is a port site metastasis in one of the ports. And you do investigate and you find there is no other disease anywhere else. So isolated port site metastasis. What do you do with this? This probably is because of the contamination, the point you were mentioning, that bag was not used. And it is very tempting, and we have also done to excise this sport after excluding by a PET scan that there is no other disease anywhere else in the gallbladder bed, in the lymph nodes, or anywhere in the body. But I am yet to see, or I am yet to talk of a colleague talking of such a patient having a 5-year survival, which means that whatever it is, whether it is isolated or not,
Yeah.
it is a predictor of peritoneal dissemination, which probably indicates poor survival.
Perhaps also the interval between cholecystectomy and when this manifests, if it is longer, then it may be an indicator of very localized disease. But absolutely, I mean, it's hard to believe that it's there and it's only localized, and resecting that would cure the problem.
So this is another idea of a survey which any young colleague can do, that you just send a survey to all those who are dealing with gallbladder cancer, that have you ever seen a 5-year survival after a port site metastasis excision? And my hunch is that answer probably would be zero or in single digits.
Right, right. Wow, so much of insights into this. Uh, Let me ask about something a little off the track. What is your view on minimal invasive surgery or laparoscopic or robotic surgery for the incidental? And then subsequently, say, as you said, if you want to do the resection, to continue to do that by laparoscopy or robot, or in reoperation also. So, what is your hunch yourself, and what do you think is how the people are looking at it?
So we were strong proponents of open radical or extended coli. And around that time, Dr. Anil Agrawal, who again has a lot of contribution to gallbladder cancer from India, he started doing minimally invasive laparoscopic at that time, extended coli. And we had a lot of differences of opinion. I never kind of supported it. But then over a period of time, both his group and especially Dr. H.S. Han's group in South Korea, they have now shown even long-term results that if done in properly selected cases, if done at centers which are experts in doing minimal invasive surgery, especially liver surgery, and in those hands, the outcome may be as good as open. And certainly, the usual advantage of laparoscopic surgery are there: magnification, better lymph nodal clearance, better clearance of the areolar tissue, because you are seeing things in the magnified way. So it's not that it is better, but it can give equally good results.
Yeah,
But two riders in properly selected cases, which are relatively early cases, and in experienced hands. So if one is an expert, advanced, minimally invasive surgeon, today I can say that I have nothing against it, but till a few months or years ago, I was still doing an
be a
open.
skeptic on that. Right. I mean, I just finally want to understand.
Robot, I don't think has a role here, because robot's main role is when you're doing an anastomosis, a difficult anastomosis. I don't think for dissection, robot, I have no personal experience, but whatever I have seen, you probably would be a better person to answer that. But I don't see whether robot will have an advantage over laparoscope.
It does provide some advantages, and people are doing it. So
Okay.
I think it'll be like what laparoscopy we were skeptical about
Hmm.
decade or decade and a half back. And I think in the future, this is
Okay.
going to be the modality. I just want to ask you, Dr. Kapoor, that we talked about incidental gallbladder cancer. Now, is incidental critical or is the stage? So, stage by stage, whether it is diagnosed gallbladder cancer or incidental, is there any difference? Or it's all boils down to the stage of which determines the prognosis?
Again, common sense would dictate that if we have diagnosed it and done the treatment in the first go itself, the outcome should be better. But evidence, obviously, it cannot be controlled. It has to be two different groups. Evidence probably doesn't suggest that. Uh, uh, the only problem in incidental is this phenomenon of bile spill, which
Yes.
we all know that occurs in about
Changes
20,
the
30,
yes,
40% of cases
40%.
of lab coli in anybody's hands. And considering the aggressiveness of the disease, I presume that would and should kind of decrease the survival of incidental gallbladder cancer as compared to primarily diagnosed gallbladder cancer, even if matched stage to stage. So that is why I say that even if there is no other indication for chemotherapy, if we know somehow that there was bile spill, I would always add adjuvant chemotherapy in these
Yeah,
cases.
I think that's a very important point. I think it makes a lot of sense. So finally, Dr. Kapoor, as we've been talking, there are a lot of areas which are missing. There are a lot of blocks of the puzzle missing. So you've seen this disease over these 3 or 4 decades. Uh, what do you think should be the focus areas for clinical research, for laboratory research, and how do you think it would impact and benefit patients and clinicians to deal with this disease better?
Although you did say in your introduction about my achievements in gallbladder cancer, but I think my only achievement, if I can say so, in gallbladder cancer is that we and other groups in India, including Dr. Anil Agrawal, TMH, and other institutions, is that we have put India on the global map, that people now know that gallbladder cancer is an Indian cancer. If we read the earlier textbooks, they used to quote data from TMH Mumbai and say that gallbladder cancer is not common in India. So that is one thing which probably we have done. Second is that we have highlighted the importance of looking into it. And I have to admit that in spite of having worked in this area for almost 4 decades now, because that article with Dr. Chattopadhyay was published, if I remember correctly, in 86 or so, or 88.
Mm.
It's almost 4 decades. But the only thing I have been able to do is to pose questions. Now it is for the younger generation to find the answers, because questions are clear. And questions are, why gallbladder cancer is common in North and Northeastern India? That is one. Second, what is the relationship between gallstones and gallbladder cancer? Is it just coincidence? Are they etiological? Or are they acting as a co-carcinogen in presence of other factors like pesticides, heavy metals, the hypothesis of BHU group, and so many other infections, Helicobacter, Salmonella. So somebody has to look into it. We did some preliminary work, but
You did something on stone analysis in
yes, yes. But as I said, that we just started answering the question. We haven't still found the answer. So people have to work on it. Third is what is very important for screening, because the key question is a young lady who's found to have asymptomatic gallstones during an ultrasound for pregnancy. Should she have a cholecystectomy or not? Because on one hand, we have the cost and the risk of cholecystectomy, including a bile duct injury. On the other hand, we have what is the risk of gallbladder cancer. So today we cannot say what is the risk of her developing gallbladder cancer. So are there any biomarkers? Are there any stone features which can predict whether she is at the highest level of the risk? Then she could be offered. So what is the role of identifying the risk of future gallbladder cancer? What is the role of biomarkers or stone markers? And
So
which,
didn't your group, you did something on analysis of molecular changes in bile of these patients and
yeah, so there are techniques. NMR is one technique. And there are so many techniques which are available with engineering institutions. I think the surgeons or young faculty or scientists who are interested in this, they should collaborate with non-medical institutions. Very recently, I got connected to a scientist in Birla Institute of Technology in Mesra, Dr. Shubha, and we've been doing some work because they have several techniques, including several methods of spectroscopy for analyzing these stones. So my hunch is that stones, because stone disease is so common in the West, but
Yeah.
there is no gallbladder cancer there. So
Yeah.
is it that their stones are different from our stones? Is it that North Indian stones are different from South Indian stones? Or is it that it is only presence of stone and there is something else which makes the gallbladder carcinogenic?
Yeah.
So
The
these are all
classic
things which need to
two-hit
be.
hypothesis.
Yes. And lastly, like in any other cancer, like PSA or other markers, we have to find a blood-based or a saliva or urine-based marker. So in that direction, all these new, the liquid biopsy techniques, microRNA, tumor, circulating tumor RNA, cell-free DNA, all these things need to be looked into. So these are some of the areas which I would urge and request my younger colleagues to take on. And at this stage, as you said, I'm more into teaching and mentoring. So if any young faculty colleague is interested in formulating a research plan, writing a research proposal related to gallbladder cancer, I will be very happy to assist in editing, polishing, and making that proposal better suited for funding.
Wow. So much of information and so many things to do for the next gen of people. Uh, Sadly, we have to come to an end. Dr. Kapoor, thank you so much. It's been just a pleasure to pick your brain, think how you're looking at the problem, and solutions that you suggest for these. So I'm sure it'll be of great value to people who are listening to it. And I'm personally uh, thankful and indebted to you to have participated in this. Thank you very much once again.
Sadiq, if you allow, I will just share one slide which gives information about a program that I have recently started. I call it Gallbladder Cancer Pathshala. So these are the four chapters: that why gallbladder cancer, what is the importance, the point which Dr. Sadiq asked in the beginning. Then, of course, it covers the diagnosis and staging and management. And last is that I try to explain that what the students today, the faculty members today can do. So anybody, any group which is interested in having this online gallbladder Pathshala, please email me vkkapoor.india@gmail.com. Thank you.
Thank you, Dr. Kapoor. Thank you
Thank
once
you.
again.
Thank you, Sadiq.
And
It was pleasure talking to you. Thank you.
hope we get an opportunity to sit again on another topic on another day.
Thank
Thank
you.
you and good night.